All right, hello everybody. Looks like we've got the top of the hour. So hello and welcome to today's MIPS Tips session on wrapping up 2020 reporting and quality and cost for 2021. Our presenters today will be Aaron Hubbard, Perrin Andrel, and Seema Rather from Comagin Health. I am Miranda Brzezinski with Mountain Pacific, and I want to thank you for spending time with us today. MIPS Tips webinars are a collaboration effort between three organizations named on the slide with the goal of providing clinics and clinicians timely information on the quality payment program and to give you a chance to ask your questions related to this program. Between Comagin Health and Mountain Pacific, we support practices in a variety of states. A few housekeeping items before we get started. Please take a moment to locate the chat feature in this webinar platform. Links to the resources that the presenters share will be posted there throughout the webinar. This webinar is being recorded. The resource links shared through chat, a link to the webinar is being recorded. The resource links shared through chat, a link to the recorded webinar, and a copy of the slides will be shared with attendees and registrants in the email following the webinar. If you would like to download a copy of the slides so you can follow along with today's session and take notes, I'll put a link in the chat where it can be located. The slide deck and recording will also be available on the Comagin Health and Mountain Pacific websites following this event. You can find the slide decks and recordings from our prior webinars, along with a lot of valuable QPP resources there as well. So please visit those sites. We have a very experienced presenters today that will be going through a lot of information, and we want to make sure to answer all of your questions. You will remain on mute throughout the webinar, but you can use the chat feature to interact with our team and the presenters. Please feel free to share your thoughts, comments, and questions with the entire audience. Members of our team will be monitoring the chat and will bring your questions forward to our presenters during the moderated Q&A at the end of today's session. Your feedback is very important to us. When you leave the webinar today, we ask that you provide your feedback on how we did and on topics of interest to you for future webinars. Watch for the evaluation survey link and please take a moment to fill it out. Thank you. And now I'll hand it over to Aaron, Aaron, who will start the presentation today.
Welcome to our MIPS Tips webinar this afternoon. I'd like to begin by talking about the 2020 reporting process. And some of you might be aware of the MIPS, CMS has applied the MIPS automatic extreme and uncontrollable circumstances policy to all MIPS eligible clinicians for 2020. And so this is good news if you've struggled reporting due to the pandemic. And so one of the things to note that you do not have to do anything in order to apply for this program, for this extreme and uncontrollable circumstance policy. And so that's good news for the physician offices we work with. Can we go to the next slide? And so a couple things, if you've not submitted any data yet to be aware of, you don't need to take any additional action to qualify for the automatic EUC policy. You will automatically be identified to receive a neutral payment adjustment for 2020, which affects your 2022 payment, your reimbursement from Medicare. And so just be aware of this. I'm not going to go through this entire, I'm not going to read through the entire slide, but just be aware if you've not submitted any data for 2020, this applications automatically apply to you. And then next slide, please, Miranda. If you have submitted some data, for example, if you submitted the Medicare Part B claims data, you don't need to take any additional action to be eligible for the automatic EUC policy. If you've submitted more than one category, you will be identified and will need to submit MIPS data. So if you've gone into your QPP portal and put, for example, some improvement activities or promoting interoperability, some of those measures, you will be qualified for the MIPS program for 2020. So just be aware of that if you've entered any additional data besides the Medicare Part B claims data. And then if we go to the next slide. If you are part of a group or a virtual group, just be aware of some of this. Again, I'm not going to go through, all of this bullet point by bullet point, but just be aware that if you are part of a group, that there is some adjustments made for the 2020 EUC policy. Next slide. If you are part of an APM, be aware too of some of the changes made to that program as well, and how it affects your submission of your quality reporting for 2020. Next slide. So if you are decided to submit data for 2020, I just want to go over a couple things that will help you be successful as you do that. The first thing is to make sure that you have your QPP account and password current. This expires every 60 days. So if it's been about a year since you've last submitted data, just be aware that you might have to go in and reset your account and password. This can be a kind of a tricky process sometimes. And so if you've not done that recently, go in and do that today. That way, if there are any problems with your account, you can get those resolved before the reporting period ends. Improvement activities. If you've not submitted or not selected any improvement activities, look at your current workflow. What is working well in your wherever you work, and then look at the improvement activities and select improvement activities that align with your current workflow. There's a couple, improvement activities that we like to recommend. For example, if you take Medicaid patients, there is a Medicaid improvement activity that's seeing Medicaid patients in a timely manner. And so there's a couple of those that are high value. For example, the Medicaid one, if you're a small practice, it's highly weighted. You only need to submit one improvement activity to get full marks for the improvement activity. So look at your workflow and then look at the improvement activities to see what works well as you're selecting those. So if you have available for the advancing care information, promoting interoperability reports in your EHR, every EHR is a little bit different. Some of them are still called advancing care information. Some of them are called promoting interoperability. Some of them are even still called meaningful use reports. And so if you have access to an electronic health record, download those measures for 2020 and review the numerators and denominators in both of your reports. As a reminder, for the promoting interoperability report, you just need a minimum of 90 days of data for that. And so it's important too, as you're looking at these reports, that we don't have zeros in the numerators, because as you go to submit your data, enter your data into the QPP portal for the promoting interoperability, if you have zeros in some of those, it's not going to accept your submission. And then for the quality measures, if your EHR has the capability to download a QRDA3 file, do that so you can upload that directly to the QPP portal to submit your quality data. If you submit your quality performance data through Medicare Part B, you can log into the QPP website and review your preliminary performance feedback report. I was informed just on Tuesday that those reports are finally in the portal. And so if you've been looking for those for the last couple of months, those have recently been updated. So you can look at your Medicare Part B claims data. Another thing that I always recommend doing is talking to your EHR vendor to see what types of MIPS reporting assistance they provide. And that's not good just for 2020, but moving forward, working with your EHR vendor as a partner to help you be successful in the MIPS program. Part of that is making sure you know exactly what buttons to click and what boxes to fill out in order to get the correct numerators and denominators for your promoting interoperability and quality measures as you report those. Another option that we have available, and there are that are still accepting new clients to the end of the month, are QCDRs. If you're not familiar with that, I would highly recommend it, especially if you're a specialty clinic. It's a registry that allow you to submit, depending on the registry, quality measures, improvement activities, and even sometimes the promoting interoperability piece. And so if you're, like I said, if you're a specialty clinic, that's a good option for you. And then I highly recommend looking at the manual attestation training videos on the QPP website. They've posted short little YouTube videos that walk you through exactly how to submit your data through the portal. And it's really easy to use. It's actually how I learned how to do it. And they're very good training videos. And then if we can go to the next slide. And so one of the things that I'm going to do, I'm going to share my screen. I'm going to do a little demo real quick. You know, one of our goals as we move on through this year is to help the MIPS eligible clinicians that we work with become familiar with the qpp.cms.gov website and the resources that are available to MIPS eligible clinicians. So if we go to qpp.cms.gov, in the upper left-hand corner under resources, if I click on that, there's a little drop-down menu. And here we have resource library. And this is the full library. There's so many documents on here, and we're going to show you how to find documents that are specific for your needs. And so one of the things you'll notice under performance here, if I drop down, we have all the way from 2017 to 2022. And so if I'm curious about, you know, what are MIPS going to look like in 2021, I can click on this button and we go from 514 resources down to 47 resources. And then as we continue to use some of these filters, you're like, you know what, I'm just a regular MIPS reporting. And so now we go down to 34 resources. And, you know, for continuity in our presentation, I want to talk about the quality reports that we look at. And so we have 17 resources that are based on quality reporting. And so we can look through this. We have the final rule that we can look at. The quick start is a good overview of everything that's going on with the quality category in 2021. We have the measure specifications, and this is good to look at as you select your quality measures and, you know, want to know more about them. I highly recommend looking at these measure specifications. There's videos involved just to see what you need to do to be successful in this quality category. If you're reporting through Medicare Part B claims, there's a quick guide for that, so you can learn more about how to be successful as you doing the claims, do that. And so the one I wanted to show you, that these are the 2021 quality benchmarks. As Perrin presents later on in this MIPS webinar, he's going to talk about the quality benchmarks. And so this is where you would find the quality benchmarks and learn more information about the individual measures and how you can optimize your score on that. And so we can look at anything, you know, we can look at promoting interoperability. If you're looking, you know, I don't know what improvement activities to do, you know, here are, you know, the improvement activities. The data validation shows you what you need to do to get credit for the improvement activities, and the quick start gives you a general overview of what's going on with the improvement activities. Okay, I'm going to stop share. Do we have any questions or anything in chat before I close?
No questions in chat so far, Aaron.
Okay, sounds good.
I just want to confirm, can you guys see the slideshow again?
Yes.
All right.
We can. Thank you, Miranda.
All right. Today I'm going to talk about quality measures, and thank you, Aaron, for pointing out those resources. And like you said, I'll talk a little bit more about that here in just a minute. So we're going to talk about what's new, what has stayed the same, and other information on quality measures for you to consider. So first, what's new in quality for 2021? First, the weight of the quality category has been reduced to 40%. However, this may increase to 65% if an exception is taken for the PI category. Another possibility is that weighting may increase to 60% if there is no score on your cost measure. So we just want you to be aware that the weighting for this category can be affected by changes in other categories. In addition, there have been quite a few changes to 113 measures. This includes changes to the specialty measure sets, including the removal of some measures. So this year, there are now 209 quality measures, with 12 measures being removed from the 2020 measures list. Next slide. All right, and here is a list of those 12 quality measures that have been removed. And this includes the all-cause hospital readmission measure there at the bottom. That's something that a lot of practices have looked for. Next slide. Okay, there are two new administrative claims-based measures to be aware of that's been added to 2021. The first one is the hospital-wide 30-day all-cause unplanned readmission rate. And this is mainly for larger practices. So just something for you guys to be just aware of. Next slide. Okay, and the next one is the RSCR, the risk standardized complication rate following elective primary total hip arthroplasty and or total knee arthroplasty. So this has a 25 case minimum, a 3-year measurement period, and it does apply to individual clinicians, groups, and virtual groups. Next slide. All right, and just a note to keep in mind, when you go to the qpp.cms.gov to search for quality measures, and after selecting the Explore Measures and Activities button, the performance year is defaulted to 2020 for some reason. But just make sure that you change the year to 2021 if you are looking for quality measures for this year. Next slide. All right, so what's staying the same for this year? Case minimums remain at 20. So you must have 20 cases in the denominator to qualify towards scoring. Otherwise, you receive a minimum of 3 points. Data completeness remains at 70%, and the available collection types are unchanged as well. Next slide. Also, there's no change in the benchmark method, and the criteria for total topped-out measures is still the same as well. And just as a reminder, with the topped-out measures that have been topped out for 2 or more consecutive years are capped at 7 points. Also unchanged is that CMS still requires you to report at least 1 outcome measure or another high priority measure if no outcome measure is available or appropriate. And then with bonus points, there is 1 bonus point available for each additional high priority measure you report after your first high priority measure. And 2 bonus points are available for reporting additional outcome measures or patient experience measures. Next slide. All right, now I want to talk about a few areas to consider when selecting the best quality measures for your practice. I believe these will be relevant this year and in the following years, especially as we move into the MIPS value pathways. So they are specialty scope, submission method, benchmarks, numerators, and denominators. Next slide. All right, here I just want to do a quick review of the information on specialty measure sets that CMS provides to clinicians. MIPS 2021 offers 209 total quality measures, as I mentioned, and each measure is either specific to their specialty, relevant to their specialty, or irrelevant to their specialty. CMS has created 46 of what it calls specialty measure sets, making it easy to identify measures that are specific and relevant to many specialties. However, many, but not all specialties have a specialty measure set. All measures in a specialty measure set are designed to be relevant to that specialty. However, only some measures are going to be specific to that specialty. And here's what I mean on this slide. In this example, the specialty measure set for orthopedic surgery includes measure ID number 375, functional status assessment for total knee replacement. Measure 375 is specific to orthopedic surgery. Consequently, measure 375 isn't in any other specialty measure set. However, orthopedic surgery specialty measure set includes measure ID number 130, which is documentation of current medications in the medical record. Measure 130 is relevant, but not unique to orthopedic surgery. In fact, measure 130 appears in several other specialty measure sets due to the nature of specialties and subspecialties. Also, be aware that some measure sets include more relevant measures than others. Next slide. All right, so here's a sample list of the different counts of measures in these particular specialty sets. One thing I should note here is that you are generally not limited to reporting only the measures in your specialty set. You only have to report 6 measures, and you definitely can report more than 6, which if you do, you can potentially, it will potentially provide you with some extra bonus points. Now, let's say your measure set has 15 measures in it, for example. You don't need to report all 15 of them. You can just report the 6. On the other hand, if you have less than 6 measures in your specially measured set, say 3 or 4 measures, you need to report all of those measures. In other words, if there are less than 6 measures in your specially measured set, you would report on whatever the total number of measures are available in that set. Also remember that you're not limited to reporting only 6 measures or less, as the case may be, from your specially measured set. This is because you may be performing very well in a measure outside your specially measured set. And I know that some practices when reviewing their quality measures have discovered this. So you'll want to pay attention to that. Next slide. Okay, while you're not limited to measures in your specially measured set, you are limited to the measures in your submission method. And I'll clarify that because I know that can be confusing. CMS offers 4 different submission methods. These are the main methods, and as Aaron mentioned, you can't submit through the portal, but these are the ones that are used mainly by small practices. So you can submit either results or data for quality measures. And I'll talk about the 3 measures that most apply to small practices. When submitting through an EHR registry, you submit calculation results, meaning you submit numerators and denominators. When submitting through claims, you submit actual data points and CMS calculates the results. When submitting with an EHR registry submission method, you report for all patients for all payers. But when submitting with claims, you report only Medicare patients. So hopefully you can see that your submission method limits what measures you can report. And while there are 209 total MIPS quality measures for this year, no submission method can report all 209 measures. However, some submission methods offer more measures than others. Next slide. For example, claims and EHR submission offer 5 times more measures than the CMS web interface, but registry submission offers 4 times more measures than EHRs or claims. As you can see, there's a large difference between submission methods. These differences appear in each specially measured set as well. Next slide. All right, here's a look at the differences across a sample list of specially measured sets. You'll notice different submission methods offer different measure counts for each submission method. For example, the cardiology measure there on the left includes 25 total measures. For reference, there are 4 measures that can be submitted using the CMS web interface. 9 measures can be submitted using Part B claims. 13 measures can be submitted using an EHR. And 25 measures can be submitted using a registry. These might make a big difference, especially if your highest performing measure is one of those extra 12 measures available in a registry submission, but not available in any other submission method. So when selecting your mix of quality measures, you'll want to pay attention to what measures you can report for the submission method that you plan to use. And by the way, you're not limited to only one submission method. It's just that many or most practices only use one submission method, or what CMS also calls your collection type. So you could use more than one submission method if you choose, but just be aware that you're not limited to just one. If you do decide, for example, to submit through ECQMs using your EHR, you will have a limited list of measures that you can choose from. You want to make sure you're aware of this as you prepare to narrow down your measure set. Next slide. All right, let's talk about some concept with benchmarks. Benchmarks divide the past performance for providers in each measure into 10 parts. Those 10 parts are called deciles. Each decile represents the performance for 10% of providers in a previous year of MIPS. Benchmarks determine the achievement points you earn for MIPS quality measures. Specifically, each decile number equals the total number of achievement points your performance earns for that measure. So in this chart, if your final quality performance falls in decile 8, it earns you 8 to 8.9 achievement points. A performance of 98% then would land in decile 8 in this example. Looking at this further, a quality performance of 94% would land in decile 9, earning between 7 and 7.9 points. And most of you know that different measures have different benchmarks, but be aware though that there are some benchmarks, measures and benchmarks that can be very different. I would recommend you try to select as many measures that have benchmarks as possible. And then as Aaron mentioned and showed us earlier, you go into the resource section on qpp.cms.gov to download those lists, and that link has been put in the chat for you. So once you have that list, you filter your chosen collection type, or in other words, your submission method, then review the measure if it has a benchmark. This is important because you only earn 3 achievement points for measures you submit that do not have benchmarks. And that means you automatically forfeit 7 out of the possible 10 achievement points, and that will eat away at your composite score. And by the way, there are more measures without benchmarks than you might think. The next slide. All right, so 15% of ECQM measures do not have benchmarks. 29% of CQM measures don't have benchmarks. And 80% of QCDR measures show no benchmarks as well. In addition, I would also recommend that you make sure the measures you select do not have a 7-point cap on scoring if possible as well. To do this, you need to again filter for your chosen submission method and then review whether the measure due to its benchmarks has a 7-point cap. You only earn a maximum of 7 achievement points for measures you submit to CMS with this 7-point cap. That means you automatically forfeit 3 out of normal 10 possible achievement points. As mentioned earlier, CMS applies a scoring cap of 7 points to measures that have been topped out for 2 or more consecutive years. Consequently, measures on your list without a 7-point cap last year may have a 7-point cap this year. So you should double check this designation each year just to make sure. Again, there are more measures with 7-point caps than you might think. Next slide. Here we see that 4% of ECQM measures have a 7-point cap and 26% of CQM measures have a 7-point cap. Again, submitting quality measures with that 7-point cap forfeits those 3 points on each measure. Next slide. All right, let's move on now to the scope for denominators and numerators. And when I say scope, I'm referring to the number of cases you can expect that you'll encounter for any particular quality measure. Denominators and numerators are 2 sides of the same coin. One side of the coin is the scope of the denominator specifications, and the other side is the scope of the numerator specifications. Now let's talk about how measure specifications either limit or expand the count of cases you should expect for denominators. Different measures use different criteria to identify patients eligible for the measure. Some measures only use 1 criteria, as you can see on this chart, like age. Other measures use age and gender, and so forth. So there could be a layer upon layer of criteria for any particular measure. These criteria act as filters for patient populations, and like all filters, the more filters you apply, the fewer results you return. And that's how measure denominators work. As you can see, measure specifications identify eligible patients using age, gender, diagnosis, treatment, procedure, and other factors. Broad criteria like age, increase the number of cases eligible for a measure. On the other hand, narrow criteria like low volume procedures decrease the number of cases eligible for a procedure. So I just want you to be aware of the implications of broad and narrow criteria. Know that broad criteria increases your denominator count and the quantity of work required. On the other hand, narrow criteria decreases your denominator count, and a low denominator count can be helpful because you only have to manage a certain number of cases. However, just be aware that missing one of these cases could adversely affect your case minimums and thus your performance. So you have to kind of keep an eye on that. At the same time, narrow criteria compartmentalize patients by specialty that could be helpful for specialists. For example, your cardiologist won't have to worry about measures with narrow denominator criteria like, say, chemotherapy. So it's best to pay attention to the denominator scope when attempting to select the best quality measure mix for your practice. Next slide. All right, so now let's talk about the other half of this measure, the numerator scope. Just like denominators, numerators are calculated from its quality measures using the measure specifications. However, numerators are a little trickier because the measure specifications define when it's too late to fulfill a measure. This concept is referred to as the case unit. In every quality measure, a case has a particular unit. These units include patients, periods, episodes, encounters or visits, and procedures that are used to determine when it's too late to complete a measure within the performance period. While all measures must be completed within the MIPS performance period, some measures have to be completed sooner than that. For episode, encounter, and procedure units, you must complete these measures within a particular time frame. It's best to be prepared in advance to complete the numerator events before you have an episode, encounter, or procedure visit. For patients and periods units, you can complete these measures within a broader time frame. In fact, you can recall patients if necessary to complete the numerator effect. With patient-based measures, you will need to look at whether the numerator visit was completed anytime in the measurement period or within some time frame relative to any encounter or at the most recent encounter or assessment. So when attempting to select the best MIPS quality measures for your practice, you'll want to consider the unit for each measure case in conjunction with the benchmarks for that measure. Next slide, please. Now, one last comment on benchmarks as they relate to your numerator scope. Some benchmarks have blank deciles, as you can see. In those measures, you can lose between 2 and 7 points if your performance percentage drops from 100 to 99.9%. While this seems crazy, that's how some of these deciles work. Again, you can recall patients and complete numerator events and measures with patient and period units. Doing so could bring you back up to that 100% and regain your 2 to 7 points. On the other hand, remember that you can't recall patients to complete numerator events and measures with episode, encounter, or procedure units. So that's just one of the implications to keep in mind for the case units when thinking about the numerator scope. Now, I just want to finish up by adding that I'm sure most of you are aware that to be successful with MIPS and keep up with the documenting of your quality measures require that you have some type of workflow or process in place. And this is where it's important to make sure that you know all the required locations, AKA also known as the boxes that you need to check in your EHR to document your quality measures you're tracking. If you think you're documenting everything for a particular measure, but the numerator and denominator information is not showing up in your reports or on your dashboard, it's best to get with your EHR representative to help you go through the documentation process to verify that measure information is being tracked correctly. All right, that's it for me. I'll turn it over now to Seema.
Seema, we're not able to hear you. Seema, I believe you're still on mute.
Can you hear me?
Yes, now we can hear you.
Okay, yeah. Hello, everyone. My name is Seema Rathore. I am in Portland office. I have been working on MIPS since 2017. Today, I'm going to talk about costs. So for 2021, the cost performance category will be weighted at 20%. So it's 5% increase from 2020. CMS uses Medicare claims data to calculate cost measure, which means clinicians, practice teams do not have to submit any additional data for this performance category. So cost is a huge subject. We can talk about it for days, but today I'm really going to give you a very high-level summary. So in MIPS cost category, there are, you can say 3 measures, or some call it 20, depending on how you look at it. So the measure number 1 is Medicare spending per beneficiary measure. And the reason it says revised here, because in 2020, all of these measures were rewritten because the way the measures were attributed to the clinicians, it wasn't making sense. For example, total per capita cost measure, certain specialty providers were getting attributed, which did not make sense. So the reason it did not make sense, because total per capita cost measures over cost of care delivered to a patient with a focus on the primary care. It's more about care coordination. So a specialty provider attributed to total per capita cost measure doesn't make sense. So that's why these measures were revised in 2020. And actually some of the specialty providers don't even get attributed to total per capita cost measure. Medicare spending per beneficiary, as you all know, that this is an episode-based measure. It measures the 3 days prior, during the hospital stay, and 30-day post-discharge, the cost. And the episode-based measure, there are about total 18 episodes-based measures. Next slide, please. So total per capita cost, as we said, that it assesses the overall cost of delivered to Medicare patients with focus on primary care. The minimum case value for total per capita cost is 20. What this means is that 20 beneficiaries must be assigned to a TIN NPI in order to be measured on this cost measure. And there are several data sources, but the most important are Part A and Part B claims data. That's how CMS measures how much the cost was per patient. The next is Medicare spending per beneficiary, and this is related to your inpatient hospital stay. Again, the minimum case value for MSBP is 35, meaning that 35 Medicare per beneficiary episodes must be attributed to MIPS eligible clinician or group in order to be scored for this measure. Now we talk that there are about 18 procedural episodes measured. 13 of them are procedural episodes and 5 of them are acute inpatient. Acute inpatient are like example is like pneumonia, whereas procedures are like cataract measures. And again, it's episode-based measure, so it again assesses the inpatient, prior to inpatient, and a little bit of post-discharge. Again, the minimum case value for the procedural episode-based measures are 10, meaning that 10 episodes must be attributed to a MIPS-eligible clinician or group for the measure to be scored, and 20 episodes for acute inpatient medical conditions. All of these measures are based on Medicare Part A and Part B claims data. Next slide, please. So what all are included in Part A and Part B claims? So inpatient, outpatient, skilled nursing home, home health, durable medical equipment, and so many other things. The reason this is important to know is this helps you to think cost in a certain way. For example, if does patient have to really go to skilled nursing home, because we know skilled nursing homes are expensive? Is there an alternate for home health? If it's a rheumatology doc, is he giving generic medications versus, brand name? So that it helps to understand if you know what all are in Part A and Part B. So these are some examples. Next slide, please. So I'm not going to talk about MSBP measure, honestly, because I have provided a lot of technical assistance for cost, and I have not seen many providers attributed to MSBP, but I have seen total per capita and episode-based measures. So again, episode-based measures are assigned services for both treatment and diagnostic services, ancillary items like imaging, labs, services directly related to treatment, and the most important is complications. If a patient is going back to the hospital from a preventable complications, that's a big dent on your cost report. So again, here care coordination plays a very important role. Next slide, please. So, okay, so now we know the MIPS measures in cost category. What do we do? Where do we start? It's always a big question. So I strongly say that go back to your MIPS feedback report. MIPS feedback report is a performance feedback summary of data which you submit in the previous years, and then it's provided to you every year. It has really some good data on your measures, on your each performance category. It even shows you your bonus points, how it was calculated, and your payment adjustment. So that's a very good place to start learning about the cost category. Next slide, please. So you can access your performance feedback report through the Quality Payment Program, qpp.cms.gov website by signing the same credentials that allow you to submit and view your data during the submission period. And from your next slide, please. From your performance period, I think it's in the next slide. You can go, there is on the left-hand side, there is a tab for a cost report, and click on the cost report, and you will see that, which cost measures has been scored for your TIN or for your clinician, and how it has been calculated. Next slide, please. So who gets the feedback reports? So obviously, any MIPS eligible clinician who has submitted data, and those even who has decided to opt in, they receive the feedback report. Anyone who is submitted as a group level, as a virtual level, as a virtual group. Those who have submitted as a volunteer do not receive any kind of a feedback report, or sorry, they report a feedback report, but no positive adjustment. One thing also, we don't talk much about, but if you do report the MIPS data, your scores are also reported on the Provider Compare website. So I don't know, sometimes it's good to perform well, because if a patient is looking how this provider is doing before choosing a provider, sometimes it looks good. Next slide. Next slide. I thought, yeah. So once you go to the cost report, this is an example of a total per capita cost. If a patient is, if your provider is attributed, how the report looks. So the first, it will tell you the total per capita average cost per beneficiary. This cost is so the way the calculation is made is that, CMS adjusts the cost based on chronic conditions, age, geographic location. For example, Oregon is, say, for example, rent is much less than the California hospital. So they do those kind of adjustment, and then they tell you what is your average cost per beneficiary. So that is what total per capita average cost is. And then on the next-hand side, on the right-hand side is measure score. In this case, it's 4.2. That's what TIN or NPI has achieved out of 10. Eligible beneficiaries, it is the number of beneficiaries whose costs were attributed to your individual TIN NPI or group. In this case, you see there were about 250 eligible beneficiaries. Total per capita unadjusted per capita cost. This is super interesting because these are the scores. These are unadjusted. So basically, these are just the raw score. Like on an average, your beneficiary really costs $13,000. So, and I'll tell you why it is important to know this. And then on left-hand side, if you see there is a download beneficiary level data, if you click on that, there's an Excel file which you can export, and it gives you a very detailed beneficiary report. Next slide, please. So once you click on that Excel file, the file has a lot of information. You can really dice those data the way you want. There are really good data in the report. You can analyze the data to understand who are the high utilizers and other costs such as imaging labs, etc. So the Excel report has your beneficiary ID, the date of birth, what measure has been attributed. It also tells you TIN NPI. That is important to know because that's how you can see, oh, this patient has been attributed to this provider. ED notification, which patient went to ER. There are certain outpatient procedural costs. A lot of information is there. I just put some important thing here. The two things, scale cost and SCC percentile, is where you might want to pay a little bit attention. The scale cost is like the actual cost, like, without unadjusted, how much a beneficiary costed for whole year taking care. And that really will give you an idea, where do you have room for improvement. And SCC percentile, as we know, is very important. That's how CMS determines how sick your patients are. And in a very simple way, if CMS knows that your patients are very sick, that much money they put aside for that particular patient. And if you're within that part of money, you're doing okay. But if you go above, then it doesn't look good. And I'm oversimplifying this for the sake of understanding, but I cannot emphasize that how important it is to make sure that you code you start coding SCC for your patient coding. It's super important. Next slide. So some ways when you can certain things which can contribute to your cost measures. One thing I would say that as much as easy it is to take exemption from promoting interoperability category, if you look at MIPS at a very high level, and if you look at the holistic picture, all category makes some sense, right? Promoting interoperability is important because you get CCD, which means like if a patient has an imaging test a week before, you have that information in your EHR, which means that your provider they may not order the same test again, right? Or in your CCD, if you have a pneumococcal vaccine, if patient took somewhere, you have that information and you are improving your quality measures. Similarly, improvement activity, there's no patient level data required to report, but improvement activity is like to bring improvement within your practice, and you can align what measure you want to work on, and you can choose the improvement activity accordingly. So there is a reason there are 4 categories, and it is interdependent. So look MIPS as a holistic rather than just as an individual category, and it will make more sense. So there are several ways you can improve, certain things can contribute to your cost measures. Annual wellness visit, very important. It helps you with coding because that's when the provider has some time to spend with the patient. They can update all the, they can spend time on SCC percentile, SCC coding, on their immunization, if needed or anything is pending, A1C test needed. So there are, annual wellness visit is really, really super important for so many things. Transitional care visit. For 2021, CMS also increased the payment for TCM visit. It's very important if you're working on improving your readmissions. It indirectly contributes to your cost category. Chronic care visit, chronic care, CCM visit, chronic care management. If you are not doing it, it's a very good way to increase the revenue for your practice, as well as it indirectly contributes to readmission costs. CCM is very successful in managing the patients with multiple chronic disease and those who are on multiple medications. Telehealth, again, accessibility is very important. There are diabetes, there are several resources where, there are diabetic educators, and some of the Medicare actually, there are several codes where you can bill for it if you provide a diabetic management education. So look into it. Nursing home patient management, that is a big thing. How is your clinic managing those patients who are discharged to nursing home? Usually in clinic, there is a lot of confusion if you get a call from nursing home and who is going to follow up, who is their provider. So having a lean workflow is a good way to, it will indirectly contribute to your cost. And so many, but I don't have much time, but one important thing I want to touch here is community level. Cost is at a community level and not an individual level. So one good example is that if you are coding for SCC, just doesn't do much because the evaluation of patient is done at a community level, which means that if a patient is also seeing a specialty doc, they are considering all that, when they are looking for the cost. So think cost as a community level that, encourage all the providers to do SCC coding, encourage provider in your community to exchange the CCDs, after visit summary. If there are resources for, follow-ups for social services, try to connect that within the community, and that's how you will bring changes for your cost. And anyone who has more, if you need more information on how to analyze your cost report, what they can do, CCM, TCM, annual wellness visit, any of those things, feel free to contact us and we are more than happy to help you. London, it's all yours.
Thank you so much, Seema. It looks like we did have a couple of questions in chat. There was a question related to next year. Will there be any guidance related to organizations who have multiple specialties in the same TIN, especially when we move to the MIPS MVPs? Did one of the presenters want to answer?
I can jump in on that. So the MVPs are still in their infancy, like they are asking for specialty groups to step forward and actually propose some of the quality measures that should be grouped together. So the beginning of March, we had the quality conference, and we did ask this question to the presenters. And unfortunately, at this point in time, they don't really have a definitive answer for that. They are getting this question repeatedly because they're not quite sure, how this is going to work for larger TINs that have multiple specialties. So that is something that they're taking into account when they're creating the pathway for these actual MVPs. So we will keep watching this and, you know, see what CMS puts out. They do have town hall meetings that you can sign up for that are on the QPP website that have specifically to do with the development of the MVPs. And if you have these type of questions, I would highly recommend that you join those so you can make sure that those are at the forefront of CMS's mind as they're developing this content.
Thank you, Miranda. We also had another question. Why does registry have all the measures and the other forms of submission don't?
Do you want me to take it, London?
That'd be great. Thank you, Seema.
Yeah, so I don't know if there is any good or a bad answer, but in general, what happens that we know that there are so many different kind of EHR. Each EHR, they get certified for certain measures. And so, you know, like Athena would certified for 10 measures, and Epic may have been certified for 15 measures, but those 15 measures may not be applicable to me. And no one can force any EHR to get certified for more measures. Similarly, Medicare claims measures, CMS is really trying to get away from Medicare claims measures. Claims measures, you know, doesn't do much. You never know how you're doing, how you're performing. And also one of the goals for CMS is to promote EHR and interoperability. So that's why they are really trying to get away from Medicare claims measure. So that's where registry plays a big role. It's like a third-party vendor. They can create a measure if you are interested in really working on any particular measure. They have a certain window where they can create a measure, submit to CMS, do testing, and there are certain requirements. But technically, the registry has a really lot of room to work on with you on the measures, and that's why they are popular. I would say that it's not very easy to work with the registry. There's cost associated. Sometimes they cannot manipulate, they cannot abstract data from your EHR, and you might have to do manual entry. But if you find a registry which is really easy to it's a registry which can abstract data from your EHR, that's a really good one, because then you do really have a lot of options.
Hey, London, this is Perrin. Can I jump in here?
Absolutely, Karen.
Yeah, and I just wanted to just comment on the rest of Deborah's question there about this isn't specific to my data. I don't know if you're talking about where you find that information, but that can be found in the resource library under quality benchmarks on that spreadsheet. It shows you which measures are topped out, which ones have reduced points. So if you look at that benchmark spreadsheet, then you'll see which measures are topped out.
Thank you, Perrin. Thank you to all of our presenters. I don't see any other questions in the chat at the moment. If you did have any last minute questions, please feel free to enter them. Otherwise, I just placed the link to our evaluation in the chat. Also, when you close out of the webinar, it should open in a separate page for you. We would love to hear your feedback. I'm not seeing any questions coming in, so I want to thank you all for your attendance today, and let us know if we can help you in the future with your MIPS reporting. And on that note, I think we will end MIPS tips today. Thank you, everybody.